Hi, everyone. A very warm welcome to our webinar this evening. This is a joint event of the Lancet Citizens Commission on Reimagining India's Health System and the Population Foundation of India. The Commission aims to lay out a citizens' roadmap to achieving universal health coverage for the people of India. It will be a comprehensive research effort that brings together key stakeholders across the social spectrum. I'm Bindu Anand. I'm a fellow in the financing work stream of the Lancet Commission. So on to our topic today. The total out-of-pocket expenditure of Indians on healthcare is roughly rupees 3 trillion or rupees 3 lakh crores. To put this number in perspective, this is more than twice the agricultural budget of the country. Despite this fairly large outflow, the average experience of the Indian patient is characterized by bouncing around multiple providers, some of whom may not be licensed, unnecessary tests and medication, and in general, what we may consider poor value for money. This theme of increasing value from out-of-pocket expenditure has strangely not received sufficient attention, despite the fact that this is the single largest source of health spending in India. Today, I'm delighted to moderate this important conversation with three outstanding panelists, Professor Christine Lagarde, Priya Nayak, and Sandy Fester. Please send your questions in your Q&A box, and we will include these in our discussion as we go along. Before I turn to the panelists, I want to spend a few minutes just setting up a framework for this discussion today because it's a fairly large topic. In a paper written with colleagues from the Lancet Commission, we identified 4 potential pathways to improve this value equation for out-of-pocket expenditures. Pathway number 1, innovate on supply-side models that provide better care to patients, including bringing in new actors, potentially from the private sector, who may be more customer-centric and willing to follow protocols for screening and treatment. So this is sort of a supply-side hypothesis, as it were. Pathway number 2, which is really on the demand side, aligning customer healthcare seeking behavior towards preventive promotive care through shaping demand actively through various interventions. Pathway number 3, bring a significantly sharper focus on health outcomes at the physician or facility level, and in a way sort of walk away from metrics such as utilization, visits, and really sort of get to the bottom line of outcomes. That's pathway number 3. And the final one is financing innovations. And is it possible to move everything else remaining the same, move out-of-pocket expenditures to be much more prepaid in nature rather than incurred at the point of service? So these are the 4 sort of broad pathways that we'll keep in the background today, and we will explore each of these in some detail now with the help of our panelists. Let me start with the supply side pathway and innovations. Why is this important? More than 80% of out-of-pocket expenditures in India go towards curative care. And if you further break that down, even within curative care, data suggests that patients bypass primary care facilities to seek services at hospitals or most specialized and higher cost facilities. All of this, of course, contributes to increasing the expenditure. I will request Priya Nayak to speak about her recent experience of what patient-centered care might look like, and in particular, share about her work with pharmacies. Priya Nayak is a social sector leader who in her most recent work has focused on exploring how the power of the private sector can be harnessed for sustained impact on the myriad development challenges that India faces. During COVID-19, the Revive Alliance, a partnership of over 20 companies that she and her team at Samhita built, worked with over 150,000 informal sector workers and small entrepreneurs. Priya, thank you for being here today, and over to you.
Thank you, Bindu. So I just want to take you guys back to what happened in COVID, right? But even just our daily lives. As we were thinking about workers and entrepreneurs and also thinking about healthcare of communities, we realized fairly quickly that, pharmacists really are the first port of call for the vast majority of Indians. And as we started kind of doing a deep dive with the pharmacists, there were 3 questions we were looking to ask. One, do pharmacists see themselves as being healthcare champions? Do they just see themselves as being sellers of drugs, or are they really vested in the healthcare outcomes of their communities? The second question that we were looking to ask is, do communities actually trust these pharmacists? That beyond just the purchase of medicine, would you actually walk into a pharmacy store and ask for information on NCDs, check your blood pressure, and actually listen to advice and actually implement it, right? And the third question we were asking ourselves is this financially viable? Can small amounts of philanthropic money really empower pharmacists to become these healthcare champions in a way that you maximize social impact, but you also generate business outcomes for the pharmacist? And so we did a study with CIPLA, and we went out and met about 1,141 pharmacists across the length and breadth of this country. These are typically tiny, tiny stores. 91% of people or pharmacists that we looked at had monthly income of less than 3 lakhs, had a single store operation, primarily rented. So these were tiny pharmacists based in really underserved communities. Here is what we heard. We heard that 38% of their customers had very little information in terms of their healthcare need, and a large majority of them actually sought that information from the pharmacist. We heard that the common complaint consistently were NCDs. And most pharmacists didn't feel like they were equipped to respond to these needs of the customers that were walking in. We heard that more than 91% were going to remain vested in the community and therefore was seeking support in terms of delivering much better healthcare practices. 92% of the pharmacists were very, very digitally savvy and said that if provided with the right support, the digital tools, they could actually work with patients, not just at one moment in time, but across their healthcare journey. That they had the capability and the intent to record information, track that information, go back to the patient and say, hey, you forgot your medicine, or why don't you go in for this kind of a checkup, etc. So this was really the survey. And then we said, okay, now we've heard that an overwhelming majority of pharmacists are keen to deliver these services to communities, but does it really play out? And so we did a tiny pilot with 220 pharmacies, and these were outside Mumbai and Pune, again, in very, very underserved communities. And this is what we found out. We found out that pharmacists, without really changing anything in terms of infrastructure, were able to offer simple things like a blood pressure monitor, right? Or a BP machine, or a blood sugar indicator, or height and weight machines, and a growth chart. So very small amounts of support and these point of care devices, along with information in terms of just the various disease pathways and where could they provide information, where did they need to direct the patient to a nearby service provider or connect them to telemedicine services, that pharmacists were more than willing to do this. We had more than 2,930 patients who got screened, which meant that patients are actually seeking this care. And all of this was done at no more than 5,000 rupees, right? At the end of the pilot, we really learned 3 things. That pharmacists, when provided with the support, are willing to offer it. Patients trust the pharmacist and are willing to go back consistently, particularly when it comes to, for example, checking blood pressure, right? Where is this individual going to go? They can't afford the machine. They're not going to go to a doctor every time. So anything that required regular healthcare checkups, the patients were willing to go and trust the pharmacist to do that. And third, this was very viable because what we did is we provided a direct connection between the pharmacist being able to deliver these services and impact on business, right? So we measured it in terms of footfalls or more trust by the community or more drug purchase. And we realized that tiny amounts of investments in improving their capabilities and really changing their perception from just being an entrepreneur to actually being a healthcare champion went a very long way. And even if you pulled out the philanthropic support, but continued the support in terms of ensuring that they had the latest information in terms of drugs or healthcare practices, they were more than willing to deliver this to the patient. And so this is what we're doing going forward. The pilot really convinced us, and combined with a survey, that all of the millions of pharmacists across the country are potential channels for delivering trusted healthcare advice to local communities who interact with them, if not on a daily basis, on a very, very regular basis. We also found out that FMCG companies and pharma companies and the government are interested in using the pharmacist as a channel, not just for healthcare knowledge support, but also to deliver, whether it's connection to doctors or alignment with health insurance or government healthcare schemes, they can become the nodal entity that allows for this multifaceted integration as far as the patient is concerned. We also realized that any diseases that require long-term management, if you support the pharmacist to be able to offer that support, they're more than willing to do it. Wherever pharmacists are encouraged to say, look out for indicators of hypertension or diabetes and connect the patient with the right pathway, again, there was very much the willingness to do that. So just to summarize, I think, the following, right? Can pharmacists be healthcare champions? Yes. Are they willing to partner far more systematically with the private sector, with the government, with NGOs? Absolutely, yes. Because it leads to not just social impact, but terrific business benefit. Are FMCG companies and pharma companies keen to partner with them? Absolutely, yes. Is CSR willing to provide support? Yes. Our pilot was actually funded by NIIF, which is India's sovereign fund. And they came in because they were interested in improving the healthcare outcomes of that community. Will patients trust them over a long period of time? Yes. And given that you're seeing a lot more digital progress, both on the side of the patient and on the side of the pharmacist, the ability to use digital tools to now follow patients over multiple years and give them the right information, the right guidance, the right connection to service providers, etc., are very much things that a pharmacist can enable. So we seem very optimistic. We're now in the process of co-creating another pilot and really scaling this up to maybe 10,000 or 25,000 pharmacists. And hopefully we'll have much better information in terms of a pharmacist's ability to really realistically, but also effectively, and at very, very low cost, deliver this healthcare support to communities across the country.
Thank you so much, Priya. That is, very compelling, and listening to you just seems also such a basic idea to say, let's go where there's already trust, where people are, going in any case, and how can we convert these to become higher value interactions? Because there is also, we also worry about, people are not seeking primary care, preventive care, and we'll talk more about that in later sections. But, I think it's fascinating to think about how to take these seemingly transactional sort of touch points and upgrade them. And I think particularly the work on hypertension seems very promising, just given that large disease burden. Let me now turn to Sandy to hear her views on the US primary care, just shifting continents a bit. Sandy Festa is a senior healthcare leader in the United States. She in particular has in-depth experience with federally qualified health centers, or FQHCs, which we learn about today, and lookalike FQHCs. These are two constructs through which the US federal government engages with primary care for underserved and rural communities. Sandy, it would be great to hear your perspectives on what high quality care might look like and the overall experience of the FQHCs. Over to you.
Thank you, and good day. America had a similar situation of question about 59 to 60 years ago, when America did not have federally qualified health centers. And to keep it simple, federally qualified health centers in the United States are also known as community health centers. And I think that there's an important distinction that needs to be made, and I'll explain. Community health centers are community-based and patient-driven. And it really speaks to a bit of why this is important to have a conversation. They started out in America with 2 health centers, and now we have over 1,400 federally qualified health centers, as well as lookalikes. And without getting into the weeds about the difference of the two, the total system of care in America is about 18,000 health centers throughout the United States. You might ask what federally qualified health centers or community health centers provide. They've always been designed to serve people in rural and urban areas that are underserved. They were originally designed to reduce emergency department utilization, and then the focus shifted a bit to primary care services. You hear a lot in America about medical homes and why medical homes are so important. The trust, the loyalty, the value that is placed in a medical home. You also may hear about the Institute for Healthcare Improvement's quadruple aim, and many of us know what that is. Access, quality, cost, and let us not forget the patient experience. These four principles are something that I think are being looked at. People want access, but not just access, they want quality. And not just quality, they want it for the right price and the patient experience. Community health centers provide a variety of different things, including preventative medicine. And I know some of you have read the article and are discussing it. Primary care is important and preventative is also. Being able to improve the percentage of mammograms completed, of pap smears completed, is so important, along with so many other aspects of preventative care. Federally qualified health centers or community health centers also provide mental health, substance abuse, dental services, transportation. My colleague Priya talked about pharmacy, and pharmacy is such an important part. I know the pharmaceutical system in America is different. We cannot go into the pharmacy and be able to buy things over the counter as you may be able to in your country and other countries. However, that interdisciplinary partnership is so important. So I stand here to tell you that maybe we could have these four pathways that Bindu has talked about could be possibly connected in such a way. Another important aspect that I have to tell you, this quality, holding doctors, nurse practitioners, midwives, and variety of other professionals to a high quality standard is so very important to be able to improve the health outcomes of people in their communities. Something that I didn't mention yet, but is so very important. Besides high quality, it's cultural competent. Our health center cares for approximately 12,000 patients. I'm just giving you a little bit of a look into our health center. We are very committed to teaching. A lot of residents rotate through, and 26 languages are spoken here. Why I share that with you is because people, our experience has been want to be cared for by people like them. So the cultural competent aspect of comprehensive primary care is so important, especially as it relates to health education and reducing barriers to access, whatever they may be. I will tell you, the federally qualified health centers take care of people all ages. And in America, they are not allowed to turn anybody away due to an inability to pay. You know, that's an important thing because care at a hospital is so much more costly than it can be provided in an ambulatory setting. Governing body of the federally qualified health center is populated by patients. So the voice of the customer is very, very important. An interdisciplinary team is priceless. and that patient-centered integrated care, whatever that integrated care could be for a population, is so important. Now, I will tell you, many people think that federally qualified health centers in America just take care of poor people, and that's not the case. In many states, there's an equal amount of private insurance as well as public funded insurance. So, as it relates to the article, I will tell you that improving the patient experience, we postulate, we've seen it happen, will increase the use of primary care and reduce the possibility of shopping that we really don't see as much in the United States as you are seeing. Provider experience, quality, loyalty, and a connection to the patient is utmost. Thank you.
Thank you so much, Sandy. I had a couple of follow-up questions just to make sure that we all understand the FQHC model better. I read that there is a geographic focus to each center. How does that work? And in some sense, has that contributed to building more of a relationship-driven care model? So it'd be great to hear a little bit about that. And then also the range of services. You alluded to it. You said these centers provide care, dental care, and transportation services, because I think that's one of the things we'd like to explore further in our research to say, is the reason why Indians are not going to primary care providers or the local clinics, not building loyal relationships, simply because there is not enough of an offering. And so they're directly going to specialists because there's just a sense of, it may be priced low, but it's not worth the travel costs even, given the limited range. So just, I think if you can comment on the geographic sort of catchment area approach and the range of services, how much have these contributed to the success of the centers?
Sure. So the geographic relationship is very important. Of the 50 states in the United States, there has always been a plan for a geographic representation, and frequently the federal government will release new opportunities to open health centers that are underserved, where people have to go more than so many miles to get to a health center. Now, there are some concentrated states, and still the focus is for reducing access and reducing barrier access. So for example, if there was a pretend state that only had 10 health centers, there are a lot of statisticians that are looking at how long does a person have to travel by public transportation or by personal means to get to a health center. In America, it's very common for people to say that primary care is consumed within 5 miles from your home, which then brings me to your second question about range of service. So it's primary, preventative. Many health centers are now adding specialty care. And I know there was a little bit of discussion about that. So the cardiology, the rheumatology, but primary care focuses on taking care of everyone and using specialty care as an enhancement, not as a primary. So your family medicine physician or your internal medicine physician can take care of the hypertensive patient unless it becomes refractory. And so the list of services range from anything and everything possible. We're really focusing also on social determinants of health in America in terms of food insecurity, housing insecurity, because we know that those insecurities or health disparities truly result in health outcome functioning. And then last, I do want to talk about this local clinic concept. Look, people aren't going to go to local clinics if they don't feel that they are the best care. And I think that this system of community health centers in America has proven that they are held responsible to high quality, high performing, equally paid providers that have joy in what they do and joy in taking care of people. And as a result, the paradigm has shifted so that just because it's less expensive or cheaper doesn't mean it has to be of poorer quality. That shift has to be taken a look at.
Thank you, Sandy. Fascinating. I also will later in the conversation come back to this notion that you talked about, culturally competent care, which I feel is so important. And maybe we've not spent enough time in India thinking about that, because the assumption is always the doctor as an expert, that's enough to draw people. But I think the whole role of translation, supporting the patient through the care journey, making sure that people stay adherent. I think there's a lot of critical things that happens after the patient leaves the clinic. And I think that's where today we are seeing a lot of loss of value. So I'd love to come back to that conversation. Before moving on to the demand side, Priya, there's a lot of interest in the pharmacy channel in the audience Q&A. And I think just overall, there's also a sense of curiosity about, on the one hand, that seems intuitive. These are neighborhood providers. How do you think about the scope for misuse, over medication? I do want to note there that that would not be an exclusive problem of the pharmacy channel. Today, we worry about doctors, clinics across private sector, public sector, also sort of over-prescribing, not following protocols. So that is the overall context. But specific to the pharmacy channel, Priya, how did you, as you plan your pilot and your scale up, how do you think about, regulating, so to speak, behavior of the pharmacy channel and aligning incentives?
Yeah, so Bindu, I think at no point in time are we suggesting that the pharmacist ever steps into the territory of the doctor, right? Or of a diagnostic lab or any such. We're not even expecting, I think there was a question to say, will a doctor actually trust the diagnosis of a pharmacist? I don't think we're expecting any of that to happen. So what we're trying to figure out is that within their very well-defined remit, given that the community trusts them, given that they are eager to support the community, what kind of tools, information, incentives can we give them to do to really optimize the potential of the role? So I think we want to be very cognizant that we're not, stepping into any territory that they're not supposed to step into. I also know that, there is the pharmacist who's running the store, and then there's a whole bunch of other people that they also bring on board. So we're cognizant of what the pharmacist can do versus what a helper can do. And I think all of those protocols are being co-created. Part of the reason that we are running this pilot with pharma companies, with FMCG companies, and with medical experts is really to ensure that we stay true to the mission of the pharmacist, but enable him to do as much as possible within his remit. So if that helps. And also do it in a sustainable way, right? I think what's exciting for the pharmacist as opposed to regular NGOs or regular sort of social sector programs is if you're able to demonstrate that when he stretches himself and supports this community, that there is a win-win. And therefore, the channel that you have to continue supporting for the rest of your life. And we found, like, as we were talking to pharma companies, those that have specific therapy areas. So a set of companies are able to come in and say, I will specialize more on maternal care, or I will focus more on NCDs. And then the neutral CSR players are coming in and saying, well, I'm happy to support healthcare sort of more broadly. So what we are also hoping is that ensuring that the pharmacist is connected with multiple types of funders, multiple types of government, private sector, diagnostic lab partners, government, etc., that you're able to co-create both a business and an operating model, a business case and operating model that allows them to do far more than what they're currently really equipped to do, but eager to really stretch themselves.
Right. And potentially a role for, just common backends in terms of protocols, referrals, etc. Really think about the pharmacy as a front end, but I think build the linkages to other points in the healthcare system. Thank you.
Yeah, just one last thing, I think just on your point, Bindu. So all of this, we are creating a technology platform. We're already working with the societal platforms team, which is the Millikanese team. Because there are many things at play, right? You have the pharmacist as nodal point of contact, but you're trying to bring in digital tools, much better communication, protocols, incentives, financial support. And so we are co-creating a mechanism so that all of these different partners that the pharmacist needs, and in turn his customers or patients need, are all being managed using that tech. So that I think any quick case of him kind of overreaching or stepping beyond the boundaries of what he is and is not supposed to do, that there is a mechanism for us to learn that fairly quickly and fix it without it escalates, right? And put in those sort of checks and balances from the get-go as we go about scaling this up.
Thank you, Priya. Moving now to the second sort of pathway, which is around exploring how demand for healthcare can be shaped. I invite Professor Christine Lagarde to share her research. Her pathbreaking work has, among others, revealed the critical and beneficial roles that traditional cultures and rituals can play in our lives, and how, very importantly, working with them rather than against them could have a powerful impact on just take-up of services, openness to working with the ASHA, the community health worker, and finally health outcomes. She has ongoing projects across the world, including in Bihar. Christine, over to you, and look forward to learning from your research.
Wonderful. Well, yeah, I'm looking forward to sharing some of the insights from the research that we've done. You mentioned Bihar, so most of the examples that I'll bring up are from there. But before I go into too much detail in terms of specifically what we found, I wanted to make a few general comments. So one is, you mentioned culturally competent care, which I think should be the kind of the first ground floor consideration before anything else is considered, for a number of reasons. One is that in reading the paper, which Sandy mentioned, on spending and how much different people in different states are spending out of pocket in care, and how tiny that fraction is for preventative care in particular. And in some cases, maybe it's 4% of the amount that they're spending out of pocket. And one takeaway from that might be that people are not concerned about preventative care. They don't appreciate the value of it. I mean, there are a variety of different takeaways that I think would be, in fact, really incorrect. In the research that we've done in Bihar, we documented hundreds of different practices. We were working in the context of maternal and child health in this case, but hundreds of different practices from both the traditional healthcare system as well as the biomedical healthcare system that people are engaging in, mothers and families, to prevent mortality, morbidity for mothers as well as for babies. Which brings me to another critical point. There are multiple health systems in India. There's not just biomedical health. And I would argue that a lot of preventative care is currently occurring, just period, and that most of this preventative care is occurring outside of the formal health biomedical system. And that a big part of the solution going forward is greater integration between what I'll call health influencers in the traditional sector or the informal sector. Priya, the pharmacists, I think, absolutely, in many cases, well, they sort of straddle this boundary, but often work in a more informal capacity. And also really leveraging the influence of health influencers that are closest to customers and to patients. Pharmacists would be an example. Bindu, you mentioned community health workers would be another terrific example. In the work that we've done, we found that community health workers have an influence on decisions to engage in biomedically recommended practices, again, in the context of maternal child health, that's comparable to doctors. So they have an enormous influence on what people are doing. And as a social scientist, I would argue if an influencer is influencing what people are doing, what decisions they're making in terms of their health, we should be working with them. There are dozens of health influencers in any kind of complex ecology of health, and we should be working with all of them, and they should be working with each other. So to increase the uptake of preventative healthcare, which is clearly critical to solving this issue, if all of your interaction with the formal healthcare system is in severe cases of injury or health and hospitals, right? This is not cost effective. It's not even affordable. Not in India, not in the United States, really not anywhere. Bringing together and integrating the suite of different influencers that patients are interacting with. And the more local they are, the closer they are to the patients, the more trust there is, the more cultural competency there is. In the research that we've done with ASHAs in particular, they have deep and sophisticated understandings of local beliefs about health in all possible domains. Unfortunately, a lot of their cultural competency doesn't necessarily translate into the kind of advice that they give, partly because the advice they give is very kind of rigidly structured by the formal healthcare system in ways that are probably essential. If there was no standardization of health messaging, there could be a great variety of problems associated with misinformation. But empowering, ASHAs and community health workers, which in many ways are cultural translators, they should be facilitating and bridging traditional health with biomedical health, which should be working together and not at odds, empowering them to do more translation and to more effectively address concerns that patients have, rather than exclusively listing out a kind of regimented list of benefits associated with vaccination or exclusive breastfeeding, things of that sort. ASHAs very accurately communicate the information that they are kind of scripted and told to communicate. The problem is there's a gap in many cases between what the concerns of the customer, the patient are, and the messaging that community health workers are, or doctors, this is not just a problem for community health workers, are providing. So if you, for example, are concerned that vaccines might compromise your future fertility or cause a variety of problems for your fetus or yourself, and a community health worker, a doctor who's scripted and what is biomedically accurate talks about the benefits of preventing a disease, that's well and good. But if I'm concerned that it might also cause this other problem, there needs to be a much clearer communication about that, about addressing potential concerns on the part of customers in a very psychologically savvy, but critically culturally competent way, working with people who are close to communities who understand the nuances of traditions and beliefs and practices and the rich systems of rituals and beliefs that live within those communities, is best positioned to be maximally effective at influencing behaviors. So in fact, there's an enormous interest in preventing negative outcomes on the part of mothers. There's no one more interested in preventing negative outcomes for their babies than parents, mothers in particular. So the motivation is there. This is really, from my perspective, very much an issue of, in some cases, access, but also translation and a failure to capitalize on the large number of important influencers that might operate at the borders of, between, or in another health ecosystem, another health system, which should be collaborators and partners and not excluded in developing better systems of communication with customers and patients.
Thank you, Christine. This is a truly new perspective, and I've never heard phrases like influencers and translators in a primary care. So this is fascinating. just to follow up on a few themes, I think lots of healthcare models, including in India. I think this was the motivation for the last mile worker, the health worker, the ASHA worker. I'm involved in the program at Dwara, in which, again, we are recruiting last mile workers. So I think part of the assumption is that if you're hiring from the community, a lot of you sort of acquire that cultural competence that comes with the territory. But obviously in practice, that's not turning out to be enough. Maybe in the training process, in the integration, they are losing some of the intrinsic cultural strengths that they have to start with. But I wonder if you could comment on maybe taking the specific example of ASHA workers, beyond local hiring. What else would you like to see in terms of preserving the quality of this cadre and getting them to be better advocates for customers, patients?
I think ASHAs need to be, well, one, persuasion and behavioral change, as we all know, is difficult. If it's difficult for public health professionals with PhDs, it's certainly going to be difficult for women who have been given no formal training in how to address misconceptions in particular. They also need to be empowered to do so. So ASHAs are, in fact, following a script of particular recommendations that are, biomedically accurate, and not veering from that, at least not much. So in many cases, they're actually not given permission to kind of go beyond a particular regimented list of facts and recommendations. So they have a script, and they stick to that, and they communicate that information very clearly. They need a more flexible script, and there needs to be, explicit training in how to address misconceptions or just address concerns in culturally competent ways, but also within some guide rails, right? It is important to have some standardization in the kind of messaging that people are receiving. So just because they have this information doesn't mean that they have been trained in how to deploy this in maximally effective ways. And I think there are parallels with pharmacists, right? There's a lot more that pharmacists could do. They do interact with customers quite a bit, but are often not empowered to do that, or given permission to do that, trained in how to do that. So it's really an issue of translation. They're not losing that cultural competency. They most certainly have it, but the formal health system isn't leveraging that currently, right. and absolutely could. And I mean, from my perspective, the initial motivation for the ASHA program is based on this brilliant recognition that ASHAs they're cultural communicators. They bridge the traditional and the formal healthcare system. They're perfectly positioned to do this translation. They just haven't been given the training and haven't been empowered, authorized, in fact, to do this. I think due to a history of just generally neglecting the traditional healthcare system more broadly, which is enormously influential and on average positive, has very few negative outcomes associated with it, which we've studied pretty extensively. So there's all this cultural capital that is there to be leveraged. It's just, it's there, just waiting. Yeah.
And Christine, I think it'd be great for our audience to maybe, if you can share an example of, in any context, it doesn't have to be India, but where you think this translation has happened well, and what impacts did that have, that would be fantastic.
Well, I think Sandy talked a lot about community health centers. I think those are exactly the sorts of contexts where this kind of translation occurs best, because every geography has a unique constellation of beliefs and practices and unique issues with particular diseases, right? Chronic diseases versus infectious disease. these different illnesses require different strategies for for communicating. And I think that there are not many contexts where truly well-functioning traditional and biomedical health systems are working in close collaboration. In many of the I've worked in sub-Saharan Africa, I've worked in obviously in North America, and in nearly all cases, there's unnecessary, at least high-level antagonism. On the ground, there's often many cases of practitioners working together, ASHAs and DIs, for example. They could work together more, but the obstacles tend to be higher level and not on the ground obstacles to what potentially could be done. But I can't think of any high level formal partnerships between traditional healthcare and biomedical formal healthcare systems.
Right. And I know you've done a lot of work on the whole issue of infant mortality, maternal mortality, and sort of tracing it back to practices, behaviors. So also curious to understand, if there is a clash of mental models, which is to say what is needed for the baby in the first hour of birth, if there is a clash of what the biomedical community believes versus what the community believes, how do these get bridged over time? How do they get reconciled? And I ask that because I think there may be insights there also for other issues such as NCDs,
Sure.
where, I think we are always worrying about just, initiation of medication is not happening because of some fear around medication, so on and so forth. So if there is a clash of mental models, what does your research suggest is the best way to negotiate that as a provider?
Well, I'll give you an example of communities spontaneously resolving some, not the conflicts of mental models, but I would say pragmatic conflicts, right? So one of the things that we came across when we were doing research in Bihar is that there's a large demand for seeking out supernatural protection for infants, which would be universal, by the way, and has absolutely no negative consequences for from a biomedical perspective. Parents are pragmatic. The more protection, biomedical, traditional, supernatural, religious, spiritual, the better. And in many cases, there's a strong demand for a priest or religious leader to bless the baby before the initiation of breastfeeding. And giving birth in a clinic means there are very few religious leaders that are personally able to attend births, right? So there's this, in some ways could be a conflict. Like, we really want the protection, the supernatural protection before we initiate breastfeeding, and yet the biomedical establishment is encouraging, very correctly, immediate initiation of breastfeeding. So how to resolve this, right? It's not a clash of mental models per se. There's just a need for additional levels and layers of protection. So one of the things that many families have started doing is having the priest call the family at the clinic or the hospital on the cell phone, and providing blessings over the phone that allow for the supernatural protection, religious protection, but also the immediate or near immediate initiation of breastfeeding. Right? I think this is a brilliant example of cultural competency and people spontaneously coming up with solutions that really serve all parties involved. Right? That's exactly the sort of thing that is zero cost, absolutely zero cost, and it is something that provides a lot of kind of psychological reassurance for families. This is culturally valuable, psychologically valuable, and again, no cost, absolutely no harm whatsoever. So there are a lot of cases where really minor accommodations for the full range of the human needs and the human experience, easy to implement, and really goes a long way in reassuring families of protection. So most of the practices, that the overwhelming majority of practices even within the traditional health system that families are engaging in, do absolutely no physical harm, and certainly no psychological harm to babies or mothers at all. And in fact, the incorporation of those practices into their experience does exactly what many of us have already been advocating for: increase, obviously, cultural competency, trust, comfort, familiarity, all of the sorts of things that are typically not associated with a hospital setting. Right? So the more we can make these environments, the more comfortable we can make them, the better. And the more influencers we can get involved in bridging the traditional and the formal healthcare system, the more likely they are to incorporate biomedical care into their preventative healthcare choices, which, as I've mentioned, they're already making those. There are hundreds of things they're doing to prevent negative outcomes.
Right. No, that was a brilliant example. Thank you, Christine. And I think the point you make is so important for what we're talking about, to say just, how much people are spending on preventive care in the formal system is not the measure of how much they value it.
Yes.
So look, scratch the surface, look at practices, look at traditions, and try and integrate that. And it also makes me think, therefore, that the whole ASHA worker, health workers, other sort of last mile workers, we may be thinking about it just in a one-way sense, that there is a body of knowledge, and I want the ASHA worker to translate it to the community, to the patient. But what we may be missing is a feedback loop for then the ASHA worker, the health worker, to bring that back into the way care is structured, what the facility looks like. Do you have an ability to call the priest from the delivery room, etc.? So maybe we are sort of missing that trait. And if there are practitioners in the audience, I think this is just a wonderful provocation for us to think about how we might understand our patients' communities better and try and do this integration that Christine is talking about. Just to pick up some audience questions at this point, Christine, for you, other than health workers, ASHAs, in your view, who are some of the other key influencers and translators in primary care?
Family members. Family members have a huge impact on the decisions that that individuals make. If you can imagine young women making decisions about reproduction and the care of their babies, their immediate family, their in-laws, are very, critical influencers in the decision-making process. Which is one of the reasons why very individualistic models of health behavior decision-making fail, because there aren't single individuals that, in some cases, individuals exclusively make healthcare decisions, but that's rare. That's definitely rare in the context that we're working in India. So bringing in the, but in family members, healthcare providers that are perhaps on the fringe of the healthcare system, that RMPs, that, even folks that might not be appropriately accredited, perhaps. We already talked about pharmacists, and then a variety of healthcare workers as well. So people working in the nutrition sector, for example, obviously nurses and people who staff clinics. There's really a whole spectrum. Dyes, priests, all influence health decision making. And critically, it's important to understand who's influencing what. So there are, certain behaviors that, for example, dyes have the primary influence over, and a whole bunch of behaviors they have absolutely no influence whatsoever. Same with community health workers. So understanding that behaviors are behaviors in question are distributed in a complex space, and understanding who is influencing what, and also how these behaviors are related to each other. So some behaviors are very closely related. Engaging in one is associated with engaging in another. Some are really not related, are really independent and not related at all. Figuring out who's influencing what and ways we could leverage influence to get greater impact, influence multiple behaviors, desirable behaviors through kind of one intervention. All of these things increase efficacy and impact. This is why understanding a complex system is so important, not just who you think should be influencing, but who actually is influencing.
Sure. Thank you, Christine. I wanted to see if Sandy or Priya wanted to come in, comment on anything they've heard so far before we move topics.
Well, I wanted to share something in terms of cultural connectedness. We call it that because this competence kind of, I don't know, might miss the mark. Christine gave excellent examples of this cultural understanding, connectedness. You know, we see it here in our health centers when a provider of whatever like ilk talks to someone about their diabetes and may need to make food choices. You know, having an understanding of the community, an understanding of if they're living in a food desert or not, an understanding if, you know, carbohydrates might mean something to me different than something to that person. I'll give another example. In the United States, our use of nicotine is lowering. And in India, it's still higher than probably everyone would want it to be. So having a paradigm shift in that direction. Use of community health workers in community health centers is also used. And meeting people that have ceased use of nicotine provides hope, encouragement, and it's not just the provider talking about it. You mentioned ASHAs and community workers, you know, being able to understand the role nicotine plays in the community. When you see the rate of death of like COPD. So those are examples of speaking with the patient and being with the patient in a cultural understanding instead of talking to. It is a partnership of success. And, you know, quite frequently we end up saying to ourselves, what would you want for your mom or your dad? And treating everyone one person at a time.
Wonderful. Okay, I want to talk a little bit more about focus on outcomes, because I think also part of the problem is we are not holding facilities, physicians accountable in terms of health outcomes, and a lot of the metrics are really around visits, you know, prescriptions, amounts spent, and you know, as we talk to people, there's also, and we ask, you know, who's a good doctor in the community, who would you go? There is a lot of just noise around some of those decisions, and not surprising given that healthcare as a field has so much information asymmetry associated with it. So I want to spend a few minutes with the panel to talk about what can help patients make better decisions at a more systemic level, rather than sort of one-on-one. And this is obviously because patients have very little information about the credibility or qualifications. Just the doctor's sign is viewed as a mark of expertise. There are very few quality markers, at least in the Indian context. And a lot of the outpatient care is, you know, is happening in a fragmented, you know, hole in the wall, private sector provider type setup. So it's really kind of objectively hard to say which is a good facility, which is not. And so in the absence of such quality markers, people likely resort to doctor selection based on heuristics, you know, shortcuts, reputation, which may or may not have content in it. Sandy, just wanted to draw on your experience a little bit. I know a core of the FQHC and the lookalike effort is around signaling. In your experience, how has branding, certification, credentialing as an approach for health centers? Has that helped sort of patients make better choices? And then, once we hear from you, I want to open it up potentially to Priya and, for us to think aloud about, is there room to do this in India, which today is a bit of a, kind of Wild West in terms of providers. So Sandy, would love to hear from you on this.
Absolutely. So federally qualified health centers or community health centers require rigorous credentialing and privileging. You mentioned that some people may be practicing in India that are not licensed. That does not occur in this system of care. So that's one aspect. The branding is very important. Name recognition as well as reputation is very important. And I do want to capitalize on quality indicators that are public reported. So there are many mechanisms in the United States where you can take a look at a hospital, but as well as a health center and their health outcomes. The number of people that are getting preventative screenings, controlled diabetes, hypertension. And then last but not least, in this arena, health centers are incentivized by the federal government to perform, so that if you have a percentage, you are compared to other centers throughout the state and throughout the country. So there's always this eagerness for higher improvement, higher improvement of primary preventative, as well as reduce in ED and hospitalizations.
Thank you, Sandy. And, so just opening it up to think about what this might look like. Priya, I wonder if you have any thoughts. I mean, we talked about this a little bit in the context of pharmacies, but this is equally also a challenge with respect to clinics. I think it would be interesting to think about, should an effort around branding, credentialing, should we anchor it as a voluntary effort, or might there even be a role for regulation around this? Just your thoughts?
Yeah, so Bindu, I'm actually going to come at it from the other side, right? That I think as healthcare professionals, we look at clinics or doctors or pharmacists through the lens of, or ASHA workers through the lens of, do the right thing for the community, right? Very rarely do we think of them as entrepreneurs or individuals who are actually maximizing for very different things like income, for example, or career progression. And so, we're looking to come at it from the other side a little bit. Because so far, I think all of us are scratching our heads to say, well, there are all of these healthcare professionals, there's all of this information out there. There is a desire for them to deliver, sort of adopt better practices, deliver better care, but why don't they do it on a sustainable way without incentives, right? Now, that model doesn't work, because then you're always assuming that somebody else is insisting that this individual self-actualize when they don't. They're literally entrepreneurs. So here's another take that, we have, which we're testing very much, right? So let's assume that the doctor or the pharmacist is an entrepreneur. Now, what can we provide this individual so that they deliver the highest quality of care? So here are the 6 things we heard. We heard consistently, not just from pharmacists, but a lot of the smaller clinics that we surveyed, that access to loans not available. So what are we doing? We're putting together a credit guarantee backed facility to ensure that smaller clinics actually get access to loans so that they can just improve infrastructure, deliver better care, invest in equipment, etc. The second thing that we heard consistently is, there is a digital revolution at play in the healthcare ecosystem, and a large number of the clinics are left out of that healthcare, sort of the digital empowerment, right? So the second thing we're doing is to say, how can we quickly map all of the digital tools and technologies that can enable a doctor or a healthcare practitioner to deliver better care? The third thing that we're asking is, there are all of these government schemes that exist for patients that they're never able to access. The doctor never tells them that, the doctor says, pay me money, but never says, hey, there are all of these schemes that you can actually go out and take benefit from, right? So can we ensure that we also plug the provider with all of the schemes that exist so that you're actually able to leverage the budgets that already exist, but are not being touched today? The next thing we're realizing is that whether it's the doctor or the pharmacist, they also need market linkages. Today, they have local market linkages, but they don't really have strong partnerships with, let's say, pharma companies or diagnostic labs or the nearest government hospital. So how do you build enabling relationships without resorting to what we call in India cut practice, right? The last thing that we're also doing is ensuring that we are consistently upgrading their skill sets. So one of the questions that we're asking ourselves is, let's treat them as optimizing individuals, and assuming that you can give them all of the other economic support to improve their own business, can you ensure that incentives are linked very firmly to delivering better healthcare outcomes? Because I think there were a lot of questions on the chat, but also questions that we get asked all the time. Is this person going to commit fraud? Because God knows they do, right? And so how do you shift them away from the need to commit fraud, but instead ensure that they actually thrive in practice-oriented business? We're literally, so I think the future of Revive, which is this blended finance facility that we run, is to irreversibly increase incomes of 10 million workers and entrepreneurs, right? And we want 1 million of them to be healthcare practitioners. Whether it's the ASHA worker becoming a healthcare entrepreneur, whether it's a pharmacist delivering much better care, whether it's a doctor operating a much better clinic. And what are all of these other inputs that we can deliver? And the last thing I want to say is that, look, for every other entrepreneur that we support, just access to these 5 or 6 things is enough. But we know that the healthcare system is very different. There is a responsibility to the patient, which is very different compared to the average responsibility that an entrepreneur has to his or her customer. And so how do we then co-create this mechanism to work with healthcare experts, with the government, with pharma companies, with hospital chains, right? All of this revolution that is happening in India today, and then integrate those best practices in a way that you build these win-win models. And therefore, the role that philanthropy plays is catalytic, but bring in access to finance and bring in government schemes and services, right? So think about it from a system lens, but put the economic incentives of the healthcare provider at the center, because very often we forget that in the attempt to maximize healthcare outcomes only for patients.
Sure. And so your view is, focus on capacities, don't worry about labeling them, but let's support the good ones to grow and thrive. I'll share with the panel sort of a live issue that we've encountered in some of our work in rural Maharashtra. A lot of our patients talk about pain being an issue, back pain, muscular pain, and this is people who do physical work for a living. A lot of the current practice involves going to local providers, and because these are people who are informal sector workers, they just cannot afford to lose a day's work, right? So there is a lot of emphasis on the good doctors get me back on my feet quickly, so I'm not, losing time. And so a lot of the practice, as it were, are things like steroid injections, saline injections, which are not cheap. It costs sort of 500 rupees per visit, including all of this. But over a long term, we know this is not the ideal course of treatment. And if you go in there, and if you have a benevolent, kind of primary physician who's talking about physiotherapy, then in some sense, he's just, okay, good idea, but I have to get to work tomorrow. So how would you think about sort of problems like this? And also, Christine, sort of your perspective on should we help patients sort of with that search for who's a quality physician, or trust that, locally that information will get processed well, because we do see some adverse choices being made. So an open question to all the panelists.
So Bindu, can I come in very quickly?
Yeah. Yes, Priya.
That's right. One is the fact that patients need to be educated is without doubt, right? And in terms of good practices and bad practices. The second is we're not expecting that every doctor or every pharmacist is going to sign up for this. And therefore, there is a bit of a, hey, there is an entry barrier. So prove that you are one of the worthy ones. Demonstrate to us that you're taking these inputs to ensure that you're consistently meeting the standards demanded by your profession, right? So
who is us here, Priya? Who is the kind of body taking that decision?
Yeah, so there isn't a body, right? I think, Bindu, what we're looking to do is to put together a consortium because it's not a single line of behaviors that you want to see. There are multiple behaviors at play, right? Am I committing financial fraud? Am I pushing medicines that I should not? Am I dispensing information that I'm not equipped to dispense, right? So I think the intent is to really create almost a collective coalition because expecting only one person to address that issue is a bit problematic. I'm not sure that's the right approach, but it's
sure
approach we are at least beginning to test out. The second thing that we're doing is because a large number of people that you talked about are in informal sectors. For our other 9 million, workers and entrepreneurs, we're also incentivizing them to say, well, I will give you a loan, but I would also if you make sure that all of your workers, for example, get access to healthcare insurance, right? Or that you're providing, days off when somebody is sick. Or if you're running a factory, are you investing in the menstrual health and hygiene or, the maternal health or the nutrition support that the women in your factories need? So think of us as kind of playing at two levels. Yes, you're working with the provider and that ecosystem, but also what is that community that surrounds them? And are you able to provide much better incentives? Right? Because these have to kind of go hand in hand. Are you going to see a perfect model coming together? No, but over a period of time, we're hoping that these two worlds will start meeting sooner rather than later.
Right. And just, I think, given how credit constrained most segments are, that's in India, at least, interesting lever. I think there's an interesting parallel with sort of private schools, affordable private schools. There's been a similar sort of debate around, parents are voting with their feet to send kids to private schools, but not all private schools are high quality. And the first generation parent probably doesn't know the difference. So you could either approach it from a ratings type, this is a 5-star private school, but what we've also seen is a set of lenders emerging in this space who are then integrating some quality outcomes to say our financing is contingent on us being able to verify some quality. So Priya, you bring up an interesting point that in addition to a formal sort of quality recognition system, there may be other levers looking at the ecosystem that are available to us. Christine, any quick thoughts on signaling and the search for quality?
I think that people respond to markers of social status really readily. So anything that can be done to differentiate those that engage in best practice, even if it's locally, even if it's at the community level, and things like self-help groups, community groups, and things like that can be involved in sort of citizen science initiatives to collect data on particular sorts of outcomes. There are ways to talk to people who have attended or worked with particular providers about their experiences, about their symptoms, about recovery, things of that sort. So again, doing kind of community outsourcing of data relevant to best practices and making that locally available would be really powerful, as people are interested in their local esteem and what people think of them. And even small markers of recognition go a long way.
And Sandy, final question on this topic to you. I know that in your centers, some of the reimbursement, I think obviously the financing mechanisms are different in the US than here. But if you could speak a little bit about, how you've linked reimbursement to outcomes, and what sorts of outcomes do you find to be reasonable, high fidelity to measure at the level of a center?
Well, let me start by reimbursement to outcome. Health centers pride themselves in allowing the provider to be agnostic to the type of health coverage the patient has. So great care for great people, no matter how much they pay. Now that's a very complicated concept for some people, but it's great for providers and it's absolutely great for patients. So if one patient comes in and pays $5 because we have a sliding fee scale based on income and poverty, and another patient pays $150, they get the equal health care. Now, that may be radical for some people. In a capitalistic society, people think if you pay more, you get better. But that's much of the conversation today, that you pay more and you might not get better. So as a result, then on how much a patient pays, I think is very important for consideration. And yes, we have federally paid for health insurance. And that's just one aspect. We have employer paid health insurance like Priya was talking about. And it even moved me to say maybe some of large factories or the likes would benefit in what we end up doing here too, of having health centers in employment sites.
Right.
Many people trust their employers. Many people may not, but if they do, word of mouth can really make the difference. And I have to tell you, it really ties into what Christine's talking about. If you have high quality, accessible, affordable, excellent experience, who's going to not run toward that? And then they tell, and they tell, and they tell. And then, like Priya was talking about, the standards, the competencies, if we can hold, however you decide or whomever decide to channel it this way, the competencies of performance and excellent care that's ethical and evidence-based.
Thank you, Sandy. And in terms of the outcomes, if you could share a little bit, what do you measure and what have you found to be reasonable over time?
Yes, so it's industry standard measures. For children, it would be immunizations. It could be exacerbation of asthma. From a pharmaceutical perspective, it could be certain medications. As we get up to adulthood, the preventative screenings that everyone is familiar with, those completions. Some centers also talk about presenteeism instead of absenteeism from work, or the daily activity of living, and the quality of life or the quality of health. So in the United States, we share best practices and evidence-based practice so that we can learn from each other as to what to put into place next to help patients. See, one thing I think we have to focus on is many times people get mad at people. And I use the word mad or angry or frustrated when a patient is having a difficult time with what you identify as non-communicable disease, like the chronic conditions like diabetes. Diabetes is a very complicated condition that's frustrating. It's depressing. Maybe you have to lose weight or you have to change your lifestyle or your activities. And for some people, they get stuck and they need a holistic approach to their diabetic care, not just a metformin or insulin. But, why do I have to make a different lifestyle change than you do? It's not fair. Am I going to die soon? All those aspects. we have to look at people holistically. It's not just the body from the neck down, it's the mind too, and the role that it plays. So I think that it's really important for us to think about each patient and what they truly need. And the voice of the patient in driving care, I think, is imperative.
Thank you, Sandy. The final pathway, just to complete the framework that we set out, we spent, I think, good time thinking about what is in the domain of providers or the supply side, what can be done better to shape demand, more transparency around outcomes, irrespective of how we do it. The final piece of the puzzle, we think, is financing. Given that out-of-pocket expenditures are so high, I think there's a real kind of issue around how are individuals financing this today in a constrained environment like India's. The answer is typically a lot of high-cost borrowing and distressed sale of assets. And this is where care is being sought, right? We also greatly worry that the initial number that I talked about, the rupees 3 trillion, is also an understatement, because there are plenty of people who are simply foregoing care because they have no way of financing that expenditure. So all of this really exacerbates the vulnerability of households. We worry about this being a driver of people falling into poverty. So one, again, lever available here. Obviously, I think the ideal state is out-of-pocket expenditure itself as a source of funding declines. I think that goes hand in hand with the vision of universal healthcare. And while in India that number is, declining, it is declining quite gradually, which means that this could be an important issue for us over the next even decade or two. So as we wait for other things to change, i.e. governments to start spending more, or insurance markets to increase their coverage from the current 10% odd to much more reasonable shares, we do need interim solutions. One thought that I wanted to share based on some of our work at Dwara Health Finance is that how can we think about everything else remaining the same? Can we start to shift out-of-pocket expenditure instead of being incurred at the point of service, i.e. I need to transport my loved one to the hospital and I need 5,000 rupees right now. At that point, it's a real scramble, because then you will do anything to get that 5,000 rupees. Typically, people are borrowing from the informal sector at very high rates of interest. Can we at least start to shift some of that from point of service to prepaid? And one way to do this, just a thought to leave with the group today, is the notion of a health savings account. At the Lancet Commission, we've been doing some research around this topic. We have a forthcoming paper that looks at the experience of health savings accounts in other countries. HSAs have been implemented in Singapore, China, the US, South Africa, all obviously very different contexts. And, in these countries, the thought has been more, how can this supplement insurance? But fundamentally, I think the appeal of the health savings account is that it lets households plan for these expenses, put aside money in advance so that you're not scrambling for liquidity at short notice. We think that potentially if we structure it well, the HSA could also be a way to encourage more preventive primary care sort of seeking. Some of our current work at Dwara, we are rolling out health savings accounts. In our case, in other countries, this was a public policy sort of measure. Here we are trying it out as a voluntary implementation in the private sector. But we are rolling out health savings accounts, which are nothing but wallets that let people save for health in a dedicated manner. So it's really just mental accounting, because generically savings is, as we know, not a terribly motivating idea, but save for health, save for emergencies, maybe so. So we are providing access to health savings accounts. And then also combining that with access to a health team that helps them think about where should I go, which facility is good quality, so on and so forth, with the aim that, we achieve two things. One, give people a better way to pay, while the spend is still coming out of their own resources. Can we reduce the distress associated with spending for health by making it more pre-planned? And also through targeted interventions, can we reduce a lot of the wastage in spending? Typically just, unnecessary diagnostic tests, branded medicines instead of generic medicines. There are a lot of opportunities, low-hanging opportunities to help customers, patients sort of spend less. So can we do both? A better way to pay for health and also reduce a lot of the wasted spending. So in the interest of time, I'll stop there, but I think there is a whole lot of interesting ideas and Priya, I think, brought up also an interesting set of points around. One is helping the individuals finance health better, but also as we think about the ecosystem, whether it's pharmacists, primary care clinics, technology providers, can financing also be a lever to help them expand the scope and range of services provided? So that really covers off all 4 pathways that we set out to explore. And I want to just give a quick few seconds to panelists in case you'd like to make any concluding remarks or observations.
I have to tell you, I'm moved and inspired. Bindu, you talked about 4 pathways, and quite frankly, I'm moved to consider the possibility that they all could be functioning together in a beautiful way. You speak of, consumer healthcare and targeted use, navigation, and the like. I think you guys are onto something that is a beautiful mechanism for improving health.
And just to pick up on that, complex systems require multi-pronged solutions, working across disciplines and sectors, and considering what's financially motivating and realistic for people is critical. I mean, this is all of these different motivations, all the different influencers need to be understood in a complex system for these things to work. So all these pathways definitely have to work together. And I think a big reason that public health initiatives haven't had the impact we're all hoping they do is that there's still this hope that you can look at single variables and single illnesses and look at the financial side of things sometimes and totally ignore it other times. This is not how decision-making works. So we have to work together in complex systems to have the kind of impact that we are aspiring to have.
And just to say that, look, it's really exciting, right? I think the work that you're doing with the Lancet Commission, the fact that you're able to bring these pathways together and think about it as a multi-dimensional, multi-stakeholder, multi-pronged problem to solve. So I think the fact that you have all of these experts thinking about it cohesively is very exciting.
No, thank you all. And I will say to myself, I'm very excited. Also with, I think, a lot of the ideas that you all talked about today, there's so much that can be done on the side of providers. And I know in the audience today, we have many people who are thinking about healthcare as new entrants, entrepreneurs, and very much have customer interests at heart. So I think all of your comments, I think, really have helped us see that there's so much more we could be doing, whether in terms of thinking about the range of services that go into a typical primary care clinic or facility. Let's be ambitious about that. Let's be ambitious about the sort of partners we would work with, tap into the cultural competence of neighborhood pharmacies, health workers, and evolve models that don't, in some sense, force everything into a homogeneity, but really draw on the strengths of many of these actors because they probably have the answer to what seem like intractable demand side problems that we all talk about a lot, such as adherence, why are people not seeking care, why are people not getting vaccinated, so on and so forth. So do want to thank all of the panelists for your time and sharing your experience so generously and really inspiring all of us on the call to aim to do more with our own work. And thank you to Pooja and the Lancet team for excellent logistics. Thank you all.